Streptococcus, Enterococcus, and similar organisms. Here are your objectives for this lecture. Streptococcus overview. So for an overview for Streptococcus, these are gram-positive cocci, just like your staph. However, Streptococcus will be in chains and pairs, so think of string of pearls. The other way we differentiate the two gram-positive genus is the catalase test. So Streptococcus is catalase negative. So we always look at our 5% sheep blood agar plate for hemolysis. The streps will often be hemolytic, whether it is beta, alpha, or sometimes we call it gamma, or no hemolysis. If you look at the slide, there's a picture there, and it will show you what they look like. So beta hemolysis, you can see there's a clearing underneath it. Kind of hard to tell in the picture, but it would be like a clear kind of, basically the red's gone from the blood agar plate. Alpha hemolysis, it may be a little bit gone, but it usually has a green tinge. And then gamma hemolysis is there's really no color change, just the colonies growing on there. So like I mentioned, beta hemolysis is a complete lysis of the red cells where we get a complete clearing of the media either directly under the colony or around it as a halo. Alpha hemolysis is partial hemolysis of the red cells, so that's where that green color comes from. It's the breakdown of the red cells. And gamma or non-hemolytic is, like I mentioned, no hemolysis. And Streptococcus is also known for fermenting glucose. Most streps are sensitive to vancomycin. Streps inhibit the respiratory tract, and they could also colonize the genital and intestinal tract as well. Pathogens include strep pyogenes, which is a group A strep, and this is the most common cause of acute pharyngitis, often just referred to as strep throat, which I'm sure you've heard before. Can also cause scarlet fever, rheumatic fever, heart disease, and glomerulonephritis. So if a strep throat is not treated or is only partially treated, like if a patient is non-compliant and doesn't finish their antibiotics, this could result into glomerulonephritis. Streptococcus agalactiae is group B. So how do you remember the pathogenesis? And agalactia is the A's. Do not go together. So strep pyogenes is group A. Strep agalactiae is group B. Group B strep is responsible for neonatal sepsis and meningeal infection. Women can be group B carriers in the vaginal tract. Oftentimes, the OBGYN physician will do a strep group B culture later on in the pregnancy so they can determine if there are additional precautions that need to be taken throughout labor and delivery after the baby is born, since it can be transmitted to the baby. Strep pneumo is responsible for pneumonia meningitis, sinusitis, and otis media, which is a middle ear infection. Viridian strep are typically normal flora. However, strep viridians can cause native heart valve endocarditis. Enterococcus used to be part of the Streptococcus genus, and now it's called Enterococcus. This is also a gram-positive cocci found in single pairs in chains. Enterococcus do grow in salt broth, and they do not hydrolyze esculin. Your most common isolates are going to be Enterococcus faecalis, which causes infective endocarditis, and Enterococcus faecium, which oftentimes can cause urinary tract infections and bacteremia, most of which are going to be nosocomial. Streptococcus pneumoniae will appear as lancet-shaped cocci in pairs on a gram stain. Strep pneumo can be normal flora of the respiratory tract, but it also can be pathogenic. And the pathogenicity of this organism results because of the polysaccharide capsule, which protects the organism from phagocytosis by the macrophages. A lot of times this will give it a dewy or moist look on the blood agar plates. Streptococcus pneumo also has an autolysin that acts on its own cell wall, which causes the bacterial cell wall to disintegrate. So what we see on a plate is what we oftentimes refer to as a donut shaped. So while the colony was domed originally in the first 12 to 18 hours, after about 24 hours of growth, you will start to see that the center has fallen and it will start to look like a donut. Streptococcus pneumoniae is the primary cause of community-acquired pneumonia. It is also a common pathogen responsible for otitis media and bacterial meningitis, particularly in susceptible populations such as young children and the elderly. These infections show the importance of the organism in respiratory and central nervous disease systems. Strep pneumo, like we mentioned earlier, is encapsulated, so that gives us that mucoid or moist-looking colony. Some textbooks may say that it looks like oil droplets, and the older colonies, once again, will look like a crater or donut, and that is due to the autolysis. So if you look at the picture on the slide, you can kind of see the colonies towards the top. You can kind of see where it indents into the middle, and that's what I'm saying when I talk about it looks like a donut. We're also going to separate strep pneumo from the Enterococcus using an opticon disc. So this is not used for susceptibility, only for identification. So it is susceptible to opticon, which means your zone size on the opticon disc is going to be larger than 14 millimeters. Then it's susceptible. If the zone is less than 14 millimeters, it indicates its resistance. Biosoluble colonies will disappear when sodium deoxycholate is dropped on the colony. At one time, all strep pneumos were considered susceptible to penicillin. Unfortunately, that is no longer the case. So you do need to do susceptibility testing based on the protocols within your facility that you are doing your clinicals or that you're working at. But there is also a vaccine now available for strep pneumo as well. Streptococcus pyogenes or group A strep. These are going to be gray colonies. These are also going to be beta hemolytic on blood agar. So what they're going to look like is they're going to have a clear zone around the colony because they're able to completely hemolyze the sheep blood cells in the agar. And that is because of the two hemolysins, streptolysin S and O. Some procedures will ask that you stab the agar with the loop after you've inoculated the blood plate, and that is done to enhance the hemolysis. So group A strep or strep pyogenes, clinical significance of that, the most common infection is going to be pharyngitis symptoms such as sore throat, fever, headache, beefy red pharynx, and cervical adenopathy. So swollen lymph nodes, patient may develop scarlet fever as well. You may also see rheumatic fever associated with strep pharyngitis, and you may see glomerular nephritis associated with pharyngeal or skin infections that are either not treated or not the full regimen was completed. Strep pyogenes are responsible for toxic shock syndrome. It can also, in some cases, cause the necrotizing fasciitis or the flesh-eating bacterial disease, which is a picture that I have there on the slide just to give you an example. It was one of the least gross ones I could find. But basically what that is it's a pretty rapid breakdown to the skin, and it can cause infantigo, and you may also find strep pyogenes in wound and burn infections. It can also be responsible for bacteremia, pneumonia, and sepsis. And once again, we're going to be using the bacitracin disc, but we're going to be looking for zone sizes, not for antimicrobial susceptibility. So strep pyogenes is susceptible to bacitracin, so any zone size will indicate the sensitivity, whereas all other streps are going to be resistant to bacitracin. The SXT, the strep pyogenes will be resistant. Your other disc that you can use for strep pyogenes is the PYR, and this is always going to be positive for group A strep. Penicillin is going to be your drug of choice for strep A. However, if you do have patients that are allergic to penicillin, you can use erythromycin as kind of your next best step. So let's transition to Streptococcus agalactiae or group B. Remember that the A's don't go together, so Streptococcus agalactiae is group B. The major cause of pneumonia is caused by this. Also, it can cause sepsis, meningitis in perinatal and neonatal periods. And remember, some pregnant women can be carriers of group B strep. Also, people who have predisposing conditions for group B can include patients with diabetes mellitus and cancer. So with group B strep, this is going to show a larger colony on less distinct beta hemolysis than group B. Sometimes you actually have to use your loop and move the colony to see the hemolysis underneath it, because it's not going to give you that big halo like group A will. A test that you can do is a CAMP test, and it's a presumptive identification. So you're actually going to streak a possible group B swab perpendicular to Staph aureus and look for an arrowhead. As you can see on the picture, it looks like an arrow, right? It's pointing right to it. So that's what you're looking for in a CAMP test. You'll look for hemolysis with that arrowhead to make sure that you're looking, and you need to look at the procedure in your textbook on how to actually perform this. Susceptibility testing, normally this will be treated with penicillin with an aminoglycoside. Enterococcus. Once again, they used to be part of the genus Streptococcus, but they have been renamed to Enterococcus. They are still a gram-positive cocci. They are catalase negative. You will see pairs in chains on your gram stain. However, these are typically out of the group D. They do inhabit the gut, and they will grow in high levels of bile and salt, so your bile escalin will be positive. Clinical significance for the Enterococcus include nosocomial infections, particularly when the patient has an underlying condition. It can be an opportunistic organism. It can be responsible for urinary tract infections. And the species that we generally want to look out for are your Enterococcus faecalis and Enterococcus aphasia. So how do we identify those Enterococcus? They are going to be non-hemolytic, typically on 5% sheep blood agar. They will grow on CNA and PEA, so go ahead and go back to your plating media sheet and look at what is needed for CNA and PEA. They will be PYR positive. They are resistant to bile. They do hydrolyze esculin, and they do grow in 6.5% sodium chloride. The treatment for these is going to be penicillin, once again, with an aminoglycoside. So we have a couple other stragglers here. We have group D, other than Enterococcus. So this could be Streptococcus bovis. Again, still gram-positive pairs and chains. They will show alpha hemolysis or non-hemolytic hemolysis, depending on how it's growing. Catalase negative and esculin positive. Strep bovis will not grow in salt broth, so that is a characteristic to separate from the other two Enterococcus. It's responsible for bacteremia or sepsis in the newborn. In the adults, it can cause endocarditis and meningitis, and most of the time your susceptibility is going to be to penicillin. Viridian strep. Once again, these are gram-positive cocci found in pairs and chains. They usually will show alpha hemolysis on your blood agar plates. So we need to be able to differentiate viridian strep from strep pneumoniae. So your presumptive identification could be using your PYR negative or opticin negative. Strep pneumo is opticin positive, so as well as biosolubility. And viridian strep, you will not see that autolytic, like that crater donut look, like you will with strep pneumo. And you can also treat it with penicillin.